Good evening, everybody. Welcome to Keeping It Real. We are back tonight with another great show. It has been a great weekend and it has been a great day for all of us in Michigan with this wonderful weather. How many of y'all happy about it? I know that y'all happy about it because we have tough seasons here, but God has been good to us, and we are so happy to be back again with you all tonight. And not only are we here, but we have a very special guest that I am so humbly grateful agreed to come on the show tonight and talk with us about something that's very important: dialysis. Dialysis. I know that a whole bunch of people know a little bit about that, unfortunately. But before we get to that, I am so happy to have my beautiful cousin. Y'all know who she is. Go ahead and wave at them, girl. Dr. Val, how was your weekend?
Oh, we'll talk.
Ah,
We can talk. You want to hear this?
oh, okay. We'll talk. In other words, y'all can't hear that part. So,
Y'all not privileged to it.
yeah, we can't let y'all hear that. So, anywho, anyhow, guess what, y'all? I got a wonderful guest here, and I'm going to let her tell you who she is and what she does. Welcome to Keeping It Real, and thank you for coming. My dear, go
Thank you
ahead and
for having
introduce
me.
yourself. Yes, ma'am. Go ahead and
Hi,
introduce
everyone. My
yourself.
name is Maisha. Yes. My name is Maisha. I am currently a nephrology nurse that works in dialysis. I have had experience working the chronic setting with patients, and now currently I work as an acute dialysis nurse in the hospital setting.
Awesome. And how long have you been working in dialysis?
I have worked in dialysis for 12 years now, starting out as a technician and more so recently in the last few years as a registered nurse.
Awesome. And can you tell us a little bit about the procedure with dialysis? What happens that brings people to the point of dialysis?
Okay, sure. So the top two reasons that a lot of people actually get on dialysis are from hypertension, which is high blood pressure, unmanaged, as well as diabetes that is unmanaged as well, type 2. Sometimes we have had patients that have had type 1 diabetes that have had issues with their pancreas. They usually have to have constant infusions of insulin. They have to have the insulin dependent. So, and another reason that people get on dialysis is are some of our autoimmune diseases, such as lupus and different things like that. That's another thing that causes kidney failure.
Now, you know what? I didn't know that. Dr. Val, did you know that? I didn't know that about lupus.
Well,
That's
it's a lot of those autoimmune diseases cause all that. Are points that there's a lot of inflammation in the body, and so the body trying to metabolize a lot of things with all that inflammation causes the kidneys to have to work harder. And so, it does push their body into kidney failure. And sometimes, even protein, I think, somehow is combined in that. The wrong kind of protein, maybe animal protein in the body, that also causes problems. And then sometimes the diet, I think Maisha would agree, certain foods in your diet encourage inflammation development. So there's so many ways to push your body into dialysis.
well, I know about the foods, but I did not know about lupus. Is it because lupus somehow affects the kidney through just it being an autoimmune disease? Is that it,
It
Maisha?
is.
I don't, yeah,
Okay. So is it common for lupus patients? Have you seen a commonality with them?
I
That's big
have. So
news
one of
to
the
me.
things I've noticed in the outpatient setting, a lot of times I'll always ask the patients, like, well, just curious to know your background. What did you have to deal with first your health? Like, were you hypertensive? Did you have blood pressure issues? Are you diabetic? Is it unmanaged? And then another thing that what I came across was a lot of the women that were on dialysis were saying like they didn't have any of those issues, but what happened was they had lupus, and along the way it affected their kidneys with all the different things that were additionally going on with their body. It affected the kidneys as well. And then another thing too, something that's rare that people don't really understand or get is ingesting a lot of medications for as our people that like Advil, Motrin, those different things affect the kidneys in large amounts. Sometimes people take medications like that every single day. Every day, taking these pain medications as help with one thing, and then they're also affecting their kidneys along the way.
I think that's a very, very good point that you just made, because I was talking to someone just a couple of weeks ago about taking those medicines. And I was saying, you got to be careful, because a lot of times people take medicine on an empty stomach, and that's a no-no, with things like that, Advil and Motrin. But I was saying to them, these medicines really do cause adverse problems to the kidney and to the heart. And the kidney and the heart are married together, correct? Because what goes wrong with that one, it goes wrong with the other one. Is that
Because of the
correct,
blood flow,
Maisha?
absolutely.
The
Because
blood
of the
flow?
blood flow for them, absolutely. So those vessels a lot of times are affected. So a lot of blood is not able to get to the kidneys because of heart issues, or even the kidneys are not able to produce red blood cells, which your body needs to create the blood to filter throughout the body. So then that affects your heart because you're not getting a lot of perfusion throughout the heart. So then you create that issue as well. So they're
Yeah, and I
definitely
think,
interrelated in a lot of ways.
okay, so let's stay there for just one quick second. What would you suggest of a person how to use? What is your suggestion in how to use Motrin or over-the-counter drugs like Motrin and Advil and Aleve? What is your suggestion? Like, to take them, not take them every month? Because some women have cramps, and so they're going to have it every month. Yeah, just give us an idea. And you
So
guys,
those medications,
let me give this caveat. I'm sorry. She is not a
uh-huh,
doctor. And
no.
this is just me asking a simple, open-ended question of her professional experience.
You froze, Vicky.
We're just going to look at a possible best way to use these medicines. Okay, go right ahead.
I'm glad you used that disclaimer because no, I'm not a doctor and I do not prescribe anything and then as a nurse practitioner either. But one of the things I would say is since those medications for Motrin and Advil can become nephrotoxic, which is toxic to the kidneys, I would suggest not utilizing those every single day. Yes, they have a maximum amount of doses that you can utilize for those particular medications, but at the same time, using them every day can become toxic to the body and to your kidneys.
And a lot of people have allergy medication as well that they use, and Aleve seems to be something that I've seen people use for their headaches. They have allergy, sinus, and then people use the Zyrtex. Is that one of the medicines also that can hurt the kidney that you know of?
I'm not familiar with the Zyrtex, but with the medications, if they are having issues like that, if it's primarily for pain and different things, I would say let's get to the bottom of it. Why are you having this pain? What's causing the pain instead of trying to relieve it through medication use? Because a lot of times there's another area that needs to be focused on in the body that we're not taking care of, but we're medicating it into just alleviate for a temporary fix, but not permanently.
So this is a question that I hope no one takes it offensively, but over your course of 12 years, have you seen, what is the percent? Well, I won't nail you to a percentage, but have you seen mostly African American patients or other ethnicities? Because the rumor has it that it's mostly Blacks that are on dialysis. So we just gonna keep it real tonight, because Black people, we have bad diets in terms of our food, how we prepare our food, what we eat, the fast foods and the grease and the butter and all of that. Has it been your experience over the last 12 years that you've seen mostly African Americans on dialysis?
I can say that honestly, in the area which I have worked, the demographic has mostly been African Americans that I have worked with. However, after moving to a different location, is it still mostly African Americans? Yes, it still is. I do see another ethnicity group that I haven't really been introduced to for the most part in my prior years of working in dialysis, but more so recently, I'm seeing other cultures more so than I had before. But primarily, the main demographic that I have seen in the settings of hospital as well as chronic has been African Americans.
And have most of the people that you've seen over your 12-year period, ended up on dialysis because of bad diet or because of medicine? Is it medicinally induced?
Talking to a lot of our male clients, a lot of them have stated that they had high blood pressure. They didn't want to take the medications that were prescribed to them because of how they made them feel, or different other reasons that we got from people that stated why they didn't want to take it. But a lot of times I see a lot of African American males in those dialysis chairs, and they'll say, if I could change anything, I would take the medication for blood pressure, or I would do other measures. Instead of having to take the medication, they would change their diet. Or some of the people, it was primarily they were diabetic type 2. They didn't want to take the medication that was prescribed to them, or they felt like, oh, I can do anything else. Or I don't have to do this at the moment because it'll go away. And that's a misconception that a lot of people have, that, oh, it'll just go away. I'll deal with it later. And dealing with it later, then you have the effects of that dealing with kidney disease. And then it's like, okay, now we're here. And now you're stage 5 kidney failure disease. And now you have to start dialysis, which we could have figured that out in the beginning. Okay, maybe this medication doesn't work for you. Maybe you don't like how this makes your body feel. Let's have that conversation with our medical professionals to say, how can we change this? This is what I'm experiencing. Is there anything else that I can take? Is there any other measure that I can help with this disease that I'm dealing with, whatever? But in the same fact, it's like a lot of times people wait too late. And that's the thing that we're seeing that's causing people to be on the dialysis machine.
Because it seems like people are not making the connection that if you have high blood pressure and you don't take the medicine, it's still going to affect your kidney. If you have kidney problems and you don't take the medication, it's still going to affect your heart. I just think people miss that because, like you said, they think it's going to go away. I'm going to bring Dr. Val in, but I want to just get just a couple of more questions in before she comes in. Why is it that when people come in for dialysis, some have to be 3 hours or 4 hours? Can you tell us about that? Why is that? Why are some people longer than others?
So that prescription for the dialysis treatments is based off of, a lot of times the nephrologist looks at the labs that they get for the patients, and they go off of that based off of if we can clear their body from the toxins and also get the fluid out in a certain time frame. So the nephrologist is the one that comes up with this. What I've noticed in the past is some of our larger gentlemen, they have had longer treatments because it takes, your kidneys are working 24 hours. We only have 3 days or 4 days out of the week to clean the toxins out of the body as well as the fluid. So if these larger gentlemen are on the machine, a lot of times they have longer treatments because of that, because they're not having this filtration 24 hours. And then I've noticed it too, sometimes the nephrologist will look at the different things that are going on with the patients, like, okay, your labs are doing very good. You have very good labs, you're doing well on dialysis, let's decrease your time. But sometimes they will start with a formula and see what it is from there and how it's affecting the patient. And then they go from there and adjust the time frame accordingly.
And then after dialysis is done, why is it that they give them the drinks that have fructose and cellulose, that shake that they give? Why do they give that when, it's known to be, those ingredients are known to be bad for the kidney?
So why that is generally the dietitians that give those drinks, correct? To the patients. A lot of times the dietitians give those out. And a lot of times what I've noticed is they give them primarily for the nutrients that the patient may lack. And that's what anything, sometimes I feel like there's a caveat to it. It's a pros and cons with it, but primarily that they have those drinks to them because of nutrients that they may not be receiving. Sometimes the patients have decreased appetites. They don't want to eat a lot. They may request them to have certain foods in their diet. And a lot of times they don't have the appetite, especially some of our older patients I've seen in the past, they don't have the appetite. So for the dietitian, in order trying to work with them and their prescription that they get from the nephrologist, a lot of times what they'll do is give them the insurance to help them to get the nutrients that they don't receive in their body. But at the same time, why they give that particular drink, I'm not sure.
Okay. Dr. Val, I've got some more questions, but please go ahead. Thank
you for letting me have some questions.
You're welcome.
Listen, I wanted to say that I would like to hear your input on I know a lot of the over-counter medications are a problem that people take. They also take supplements and, of course, diets. There's also the propensity for certain male or female, mostly male, to avoid too much dependence on doctors, or people have a fear of what would happen if they go to the doctor. So those might be some of the reasons why that have not been factored in, or maybe not even, the statistics aren't completely out there of why the African American community is there. I do know that high blood pressure is more prevalent in the African American community. Well, things drive the blood pressure up, so lifestyles and outside things that you had nothing to do with can cause that problem too. But a big part of why people do suffer with, or may not suffer with, having to go on dialysis could be the way the body metabolizes what you're taking. So, for example, if it's an aspirin or something that is metabolized by the kidney, or I'm sorry, by the liver, or if the spleen metabolizes something else, I guess that's that anatomy and physiology part where it talks about how much it does to the body. Hey, you okay? I'm scared for you. Love you, girl. My cousin, I'm messing with her. But how it metabolizes, the body. So some of those things may or may not. Do you? Well, that's the dietitian area, right? But I think those are some of the other reasons why too, because some people are going to have more of a propensity to go and get something over the counter than to go to the doctor and have to depend on them because they have concerns. Yeah.
I want to say to the audience
That's
listening, and
very
before I
true,
say
though.
that, go ahead. I'm sorry. Say that again, Maisha.
No, I was saying that's very true. A lot of times people are. We've known over the years, of course, many different stories and different things we've heard of. People are afraid of the medical community for various reasons or different things people have experienced personally. So that's very true. A lot of times people will like, I know this remedy, or I know somebody that experienced this. This is what they have taken, instead of consulting do that instead. And I would try to convince people or try to encourage them to at least speak to the doctor and let them know what they're experiencing. And also remember that if you don't like one particular physician or something, or maybe they don't, personality wise is different for you. It's okay to try somebody. So it's okay to go somewhere else. It's okay to advocate for yourself and say, hey, this doesn't work for me. I'm going to go somewhere else. But at the end of the day, if that you like that doctor or not, you feel like they're able to help you, your health is on the line, and you're the one that's end up or sick. It's not going to be that doctor. So you have to advocate for yourself. And if that doesn't work for you, find a second doctor, find a third, or fourth, fifth, or reach out to your community people and try to see, hey, do you have a nephrologist or somebody that you work with? How do you like them? Are they listening to you when you communicate with them? And different things like that. But I just would encourage people not to give up. Never give up. That's it, because I've seen that too. So
You have a question on the screen. Do you see all ages, mainly male or females?
So I've seen all ages. The youngest person that I have dealt with, honestly, there's also a children's hospital. They have a children's dialysis department. So there are kids that sometimes have issues in their youth from various diseases that they have to be on dialysis as well. But I've seen I think the youngest patient that I've had was 18. And they actually they had a kidney transplant as a young person, but they did not want to take the medications. They were like, my friends aren't taking these medications. I want to hang out. I want to enjoy my life. I'm young. And then they came into our unit and they were on dialysis. And that was something for me that was really hard to see, because it was like, wow, if we could have reached you a little earlier, to try to at least encourage you to take the medication or something, so you went in up here. And now they've been on the machine or dialysis treatment since they've been back, and they're in their 30s now.
So I have a question about the pressure. When patients come in for dialysis, are they coming in with a prescription from the doctor of how much pressure and all of that, or is that determined by you all, the staff, once the person gets there and you all see the medical information?
No, that's given by the doctor. So the nephrologist writes a prescription out, and the staff at the unit just follows that prescription.
Okay.
So a lot
So
of times the doctor
during,
has seen the patient, and they'll.
because isn't it true that too high of a pressure can cause the ejection fraction of the heart to go bad?
Are you saying for the goal, like how much they remove? I'm sorry, I'm trying to.
So I'm doing this show because a lot of people know and some don't that my mother was on dialysis, and my mom was put on
Mhm.
dialysis at the age of 88. Yeah, 88. And she was on it in October of that year. I believe that was 20 October of 2020, and her ejection fraction at that time was 55. When she, by February, her ejection fraction was 35, which was the following year. So that's 2021. By June, when God blessed me with a concoction to, along with changing her diet, and she came off dialysis, her ejection fraction was 25. Is that because of the pressure that was administered? And I'm not asking these questions for lawsuits and all that. I'm asking for educational purposes and to be able to help people. Because also, many people know that one of our dear bishops uh, had dialysis and came out. I think it was his first or second day. He had just started, and he died in the car on the way home with his son. So clearly, the record shows that the heart is affected also by the pressure. Is that correct? That's why I asked that.
Okay. I asked when you were to clarify for pressure because when we run our machines, we utilize a goal and also for as the rate in which the blood pump runs. So that's why I asked pressure because there's multiple things in my mind when you asked about that in regards to dialysis treatments. So one of the things that is affected, of course, the heart is affected by dialysis. The blood flow rate is one of the things that affects that. And then there's different pump speeds. So you have 250, that could be your lowest at a outpatient. I'll say outpatient because I work in a hospital too. So we'll talk about outpatient. 250 blood pump flow up to 500. And if you utilize a catheter, maybe the maximum blood flow pump for that is 450. The faster that is, that rate of blood moving in and out the body, in and out the body, of course, that's going to affect the heart. So a lot of times, just to give context to what you're saying, I work in the hospital setting as well. And sometimes with our patients that they start on dialysis in the ICU, they utilize a method called the SLED method, which is a lower pump speed because these patients, of course, if they're in the ICU, they're critical patients. They're very, very sick. So you would never want to run them at that high blood pump flow because they're already compromised. A lot of times they're intubated, they are sedated, they have a lot of different things going on. So to answer your question, it does affect it for sure.
Can
In
I ask
a
you?
lot of different ways. Yes.
Yeah, they so now you're hemodialysis,
Mm-hmm.
right? Is it just hemo?
Yes.
So you don't do the peritoneal.
No, hemodialysis.
Okay. Is there any time that, like, because of the heart's weakness and things that would cause it to put more strain on the heart, that they ever direct the patient to try peritoneal dialysis, or that's all decided by the nephrologist?
That could be decided by the nephrologist, but what I found too is sometimes people aren't even introduced to those different modalities. Sometimes they don't even know. So a lot of times when you start a treatment, if you're coming into the unit, they would this is what could happen. Disclaimer, because it may or may not happen. But they would talk to them about different modalities. Okay, so we have hemodialysis. There's also peritoneal dialysis. There's home hemo. There's different things that should be explained, honestly, to patients so they understand that you don't just have to come into the unit for hemodialysis treatments. Because if you are experiencing different comorbidities in your body or certain age ranges, that may be more effective for them to utilize peritoneal dialysis for them because it's a gentle process versus being on the machine with the high pump flows or different things like that. So that is something, another thing that can be talked about more so among medical professionals. Are we doing patients a justice when they come into those clinics? Are we talking to them about the different modalities that are available? Are we looking at age ranges and how this affects them generally for as the age? Like the oldest patient that I've had dialyzed was 100 years old. Yes, they were older, but at the same time, it's like, what else can we do to help you at
100.
this age?
This person came
Still
in at
thriving.
100.
Started at 98 and stayed to 100. That was the last time that I seen that patient. But they stayed a couple
My.
years. They started really older, but at the same time, it's yes. So I see
And
what you're saying too. Like, would that help to do another modality? For sure, I would agree that it would. Sometimes it just depends on the nephrologist talking to them, and also the staff. Like, okay, hey, we have this patient this certain age, or this is what they're experiencing when they come off the machine. Every time the blood pressure is low. Okay, so we need to look at the prescription. Or if every time they come off the machine, they feel really weak and tired, we need to look at stuff because there's things that are going on here that is at this point kind of not doing them a justice too. So we need to look at a different, all different measures and see how can we help them.
I'm happy to hear that at least you discuss and consider the other modalities that may be less harmful and strenuous on them, and then able to have that discussion with them, and then perhaps the nephrologist will change the prescription or change the modality. I'm happy to hear that.
can you, for the listeners, you're
Mhm.
you're using medical terms, and everybody clearly don't know what that means. So can you explain those three different modalities that you gave? The
Okay.
hemodialysis. Okay,
Okay.
go
So
ahead.
hemodialysis is when you are on dialysis, but you are in the unit. So you go to an outpatient facility where they put you on a dialysis machine where it filters out the blood, filters your blood, take toxins out as well as fluid off of your body. So that's outpatient. That's usually in a clinic you go to 3 times a week or 2 times to 4 times a week, depending on what the nephrologist will prescribe for you. When I mention home dialysis, what that is the same thing, but the patients are in their home setting. So they work with the home nurse before they even go to the home dialysis setting. They work with the home nurse to train them to make sure that they have support, a support person with them, as well as they're capable to be able to administer the dialysis treatments to themselves. And that takes a certain time period for training for that. Peritoneal dialysis is when they insert a catheter inside the peritoneal cavity, inside the abdomen. So there's a cavity inside the abdomen, your belly, which they insert a catheter, and that catheter is utilized to perform dialysis for you without the blood. So there's a solution there's utilized for that you insert it into that catheter. It dwells in your peritoneal cavity for a certain duration of time, and then after it cleans that out, all those toxins and the extra fluid, depending on what solution that the doctors may give you, then you connect that different. That basically you will drain that catheter. In so many words, you'll drain it, and then you remove those toxins as well as fluid off of your body. So it actually stays in that cavity in your belly for a certain amount of time. It just depends on like prescriptions and stuff for that too.
Okay, so the doctors prescribe what length of time the peritoneal dialysis is gonna
And for
go.
what I understand, 'cause I've never worked in peritoneal, but from what I understand for home, they work with the home nurse with that. So
Okay,
they'll train them how to do that and they'll go from there.
I wanna hopefully help people by asking these next couple of questions.
Okay.
So when people come in for dialysis, they come in with a script, and so they have either three. Is there anything less than 3 hours? That do you have
I've
patients
seen
that
2.5 hours.
is that the lowest time?
Two and a
The
half is
less
the
time
lowest I've
between.
seen. Hmm.
Okay. And so so they come in, and based on the prescription is how you treat them. Now let's talk about, I kind of mentioned what happens with the heart. Dialysis does mess up the heart if not careful. Um, what happens with the kidney? Dialysis flushes out, but eventually does the kidney die out from dialysis? Does it weaken it over time?
That's a good question. So a lot of times, if they've already started on dialysis, they already have a certain percentage of kidney functioning that's left. Sometimes people do come in with residual functioning or function of their kidneys that they still have a little bit of ability to still urinate, still have a little ability left to assist, not enough to be sufficient for them to survive off of dialysis. Over time, sometimes that can decrease over time with being on the dialysis machine because the kidneys aren't doing anything. But the primary goal is to preserve that residual function they may have, whether it's 15%, 10%, or whatever it is, through prescription by not pulling too much fluid. Because if you're dehydrated and you're pulling too much fluid, and we have to flush you with fluid because now we've dehydrated you too much, then now we're causing another issue. So the goal is to basically see what that prescription is. If we're seeing this patient is consistently having issues, and you could look at them when you assess your patient, like, okay, at the end of treatment, this patient is very dry. They're thirsty. They're like, hey, I need something to drink right away, or they're passing out. They're very weak. Okay, maybe this is not good. But that comes into with the help of the professional, like whoever is working with them, like, okay, they have to notice it too and be passionate enough to advocate and see what's going on, not just put a person on a machine and say, hey, we're going to do this treatment. This is that. I don't know what else to tell you. No, it has a lot more to do with it versus just putting a person on a machine and going about your way. You have to be compassionate about the person, also what you're doing, and then also following up with an assessment. You do a pre-assessment. Okay, this is what I noticed in my pre-assessment. Maybe they have a little bit of fluid on, or maybe their weight is this, because outpatient in the clinics, you have a target weight, which they call dry weight. If the patient comes in and they're already at their target weight or their dry weight, or what they are usually dry weight, that is your weight you would be without any fluid on. They call it your dry weight. So if they see that they come in and they're already at their target weight, maybe 0.5 or 500 milliliters over, so maybe we don't need to take 3. Most certainly we don't need to take 3 off, unless we're seeing something else going on that has to do with our assessment of them. Maybe they're short of breath or different things like that, or we're seeing swelling. Then maybe the target weight needs to be adjusted. But primarily it comes along with that professional that's worked with them to being vigilant, aware, and doing assessments thoroughly to make sure that you're helping the patient and not hurting them in the end.
And I don't think that people realize there are reports that you do on a monthly basis, blood work, and patients are they are privy to those reports. But can you tell us, do most people ask for those reports?
So at our unit, the dietitian actually will go around with them. Each month there should be a meeting that is had with the dietitian or the social work. Somebody should be coming around, even your nurses and stuff that are taking care of those different things should talk to the patients about their labs. And also if those labs are abnormal or not within the range they should be, they should talk to them. But that shouldn't be every so often or quarterly thing. That should be monthly, going over those labs, because we draw those labs monthly. I'm not sure what other facilities do, and I won't say where I work, but at the same time, that should be discussed monthly with the patient to see and gauge how we're doing. Is this adequate dialysis or is it inadequate for them? Those labs gauge the actual prescriptions, to be honest with you too. A lot of times seeing those labs can gauge a lot of things, like, okay, well, maybe we need to change this up, or this is working for them. So,
yeah, I didn't catch your last words because something was happening with the computer. Say that again, your last words.
I was saying it just goes, those should be talked about monthly, the patient. There should never be a time when that stuff is quarterly, and no, it needs to be talked about monthly because that helps with the prescription.
Yeah. And that's why I wanted to, I was very focused on my mom, and I was very dedicated, face like a flint to the wall in prayer, asking God to help me, because I felt that my mother was not in good hands. I felt exactly what you said, that the person on the other end performing the dialysis must have compassion. And I'm hoping that the show tonight will educate people to understand that if you are a person that has congestive heart failure, or like you said, blood pressure, diabetes, if you have these conditions and you have them for a long period of time, and some people don't even need it for a long period of time, you can mess your kidney up by dehydration. You can mess your kidney up by drinking too much pop. eating the wrong, as Dr. Val said, the wrong food. So there's a lot of things that can drive you into dialysis. The thing is, if you're going to go that way, you got to ask questions. You got to be aware. People just don't go in and let them do dialysis on you, and you don't ask to see your reports monthly. Watch your blood. I watched my mom's blood work like a hawk. I
That's
I
good.
yes, I required them to give me her blood work once a month, and I took her to get blood work at the clinic once a month. Now that's a lot of sticking, and somebody might say, well, that's a little bit much, but I needed to do that because there were times that the blood work that they took did not match the blood work that the clinic took. So I wanted some answers to that. I wanted some answers. And so I think that it's important for us to do this show to let people know that just because you get on dialysis, and this now is going to be a question, doesn't mean that you cannot come off. Can you give us the instances that you are aware of in your experience where people have been able to come off? Before you answer that, let me clarify further. The Lord blessed my mom to come off, and she's never returned. It'll be 3 years next month. But here's the deal. She never went back, and he brought her off. But some people have come off and went back because they didn't do what they were supposed to do. My mom was blessed because her kidney was not diseased. Her kidney had not shriveled up. So it was the same size as a kidney should be, a 10 diameters or something like that. Can't remember now. But her kidney was a normal size. So she went in with great possibility of coming off, but she would not have come off, if God hadn't done what he did. But he gave me the knowledge to change her whole diet. Listen to me, you all. I changed her diet. So can you speak to that, Aisha?
So,
The
for as
coming off.
people coming off of dialysis, I have seen in a few instances that people have. They started it, whatever happened along the way, but sometimes they have come off of it. Sometimes people have acute kidney injuries where they only require dialysis for a certain amount of time, where they may have an injury that's outside of the kidney, it's not intra kidney, which is inside the kidney, and have damaged it that much. But sometimes the kidney, and sometimes they call it waking up, they need a little help.
Yes.
Sometimes they have these injuries and they have to have dialysis for a certain amount of time, and then the kidneys go into this phase where they're working on their own again. I've seen that before. Not a lot of instances of it, but I've definitely seen it. And then in the hospital setting, now that I work in, I've seen that as well, where they've been in the ICU and they've needed a little help to regain kidney functioning, and then along the way, they start urinating a whole lot again. The labs start getting well. The creatinine levels go down. So
Mhm.
I've seen it happen for sure.
Well, yeah. And so my question is it a better chance for a person to come off the kidney, I mean, off the dialysis, if they know the state of their kidney? Because I requested a biopsy. That's how we found out about my
Mm.
mom's kidney being so well. There are people that I have spoken to, they didn't have biopsies. So they don't know what their kidney condition was when they walked in. So that's what I'm asking you. Is it so that as long as the kidney, if you know the answer, is it so that the kidney has a better, or the patient has a better chance of coming off if the kidney is not damaged or shriveled, and like you said, is not diseased inside, than a person who's not?
They may have a better chance, but I believe that would be a better question for a nephrologist to
Okay.
answer that, like to actually go into the depth of the instances of that and what they've seen for that. I would say that would be a better question for the nephrologist. But as you said, I think it would be good to ask people, for people to even ask for the biopsy. Some people don't know that and they don't ask for it because they feel like it's too late. So that would probably be something that they can discuss with their nephrologist. Like, okay, is it possible to have a biopsy to discuss further things that's going on with the kidney? So I would say that's a good option for people to do.
Yeah. I got some more questions, of course, but Dr. Val, you want to chime in?
Well,
Yeah.
we were talking about a moment ago about the dryness of the kidneys. They're drying the kidneys out, or yeah, they will do an exam or a reading of what they were before treatment and then again after treatment. The question would be, I know that the kidney is, or the dialysis is designed to take that excessive fluid off the body, which means there's a drying, so to speak. And I'm concerned that possibly there may be times when more than usual, if you say that they don't really care, I'm not care. I shouldn't put it that extreme, but they aren't as attentive and as connected and to the patient, and perhaps more was taken off, and they leave weak and just very, very ill. Is it possible that those are times when they may have received too much dialysis, or the amount that was taken off may have been too much?
Good question. So for that, in an instance in that case, I would say if they're experiencing that, more than likely the fluid removal goal of how much fluid to remove was too high for that patient.
Mhm.
So maybe they're supposed to run 3 hours. 3 hours could be a good prescription for them. However, the UF goal or ultrafiltration or fluid removal goal is too high. So then that's where they should see. And sometimes that's noted. You can see that during the duration of the treatment, because you may see the blood pressure start dropping. The patient may come in at the blood pressure of one, let's say 150 something. And then we're in an hour, you notice, oh, it's already 120. There is a medical professional to kind of look at that. This is dropping excessively. Maybe this goes a little too much. Maybe we need to reach out to the nephrologist. Maybe we need to back off. A lot of times people have a little bit more leeway outpatient to kind of look at those goals and adjust them. However, it has to be one of those things to be vigilant. If you notice the blood pressure dropping excessively like that in an hour's worth of time, even in the first 30 minutes, maybe we need to adjust this very quickly so they can get through the 3 hours, but not feel like they've been run over by a truck. Because that's some of the words that our patients have said. And it's like, okay, this wasn't appropriate for you at this moment in this day.
So in a case like that, you would probably have to, even if it's so bad and they're struggling, their passing out is too low, send them by way of ambulance over to the hospital to be cared for, or even some go home and then find out they can't rebound from it and you lose them. I guess, all of those factors play a role in why people don't even want to take it. Sometimes they feel so bad afterwards, they just say, I'm not taking the treatments anymore. I've known people to do that. And consequently, you lose that patient, but it's not because of the clinic or, the treatment that was given. It's just that they feel that this is giving them such a horrible feeling. They don't want to go in and then have to come back out and live with those dreadful feelings and that, discomfort. So yeah,
Also,
Mhm.
go ahead. I'm sorry.
No, I was just thinking, some going to the hospital, some going home, or even some that just decide, I'm not going to do it anymore.
And I've seen that too with some of the patients. But if they're from what I would say as a clinician, as a patient, if you're seeing a patient that's really weak at the end, because a lot of times we have to take blood pressure at the end before they even get to that place where they're walking out of the unit or even being wheeled out of the unit. Assessment is key. If I'm seeing this, we have saline available to do fluid resuscitation, help them to get better. If they're feeling dehydrated, if they're feeling weak, a lot of times that blood pressure is dropping. And to be honest, sometimes the blood pressure that you're seeing is not the actual blood pressure. They always tell you, look at the patient. What do they look like? What are they saying? If you're seeing a blood pressure that looks this way and the patient is consistently telling me, I don't feel well, I don't feel well, something's going on here. Okay, well, maybe the blood pressure is dropping it and my blood pressure machine is not capturing it at the moment because maybe it's dropping excessively. Maybe it's dropping very quickly and I'm not capturing that. But if I'm seeing this is happening with the patient before they get out of that unit, no, let's give more fluid back because we have probably taken too much. So let's give you fluid back and then let you sit here for a while and reassess how you're doing then. And I've seen it happen over the times. Like people would say, okay, I don't feel well now. Okay, let's give some fluid resuscitation back to you. Give you some saline boluses. Get your blood pressure and let them sit for a while. Yes, we know this is rotating. We have time frames and different things like that. But the key is to make sure that my patient is well and that they're not going out of here. And first of all, they have family. That's always been my thing. Every person I've worked with, they have a family that loves them and wants to to see them back in their care, well, not going to the hospital.
Right.
So that's one of the things, like if they're feeling that, like they should be given some type of fluid back and assessing over time. Okay, maybe we need to let them sit there a little, maybe 15, 20 minutes. But I've seen a lot of times that they felt that way, maybe coming off, but then sitting there and getting those saline boluses back, they felt better. But not assessing that and not being vigilant and just letting them go, like, okay, yeah, you don't feel well. This looks good, but okay, no. Because like you said, you'll have patients that and I've seen that too, where patients like, I'm not coming back. So a lot of times what I do, let me bring a chair. Let me sit here with you. Let's talk about it. What are you feeling? Why don't you want to come here? What are you feeling at home? Because sometimes it's not immediately after treatment. Sometimes it's a couple of days after. I done had patients go home and call me on the phone like, hey, Maisha, this is what I'm going through. What should I do? But you have to build that rapport with your patients so they know that you care. They understand that you're not here for, like a lot of times they say they feel like people are there for a paycheck. That's not, and that's not cool.
I think it's important, everybody that's listening, I can't stress it enough. I'm going to sound like a repeating animal or whatever. But my point is, you've got to ask these questions. You've got to, when my mom was in dialysis for 9 months, I was a nice person to them with a bag full of questions. I treated them nice because I wanted them to respond to me honestly. And I don't know if they responded to me honestly, but I felt like that they were responding to me honestly. And when I would take my mom to dialysis, you guys, I didn't just drop her off and leave. I went in there. I asked questions. I weighed my mom in. I watched them weigh her in. So I got the fluid numbers. I asked about the pressure like you talked about. I got the word pressure from them. So that's why I use that word. But I ask questions. That's my point. Ask questions. And as she said, here's the other thing. Because I didn't feel comfortable at one site, I requested my mom to be moved to another site. You can do that. You don't have to you don't have to go where they send you. Another thing is there is a urine analysis that is done. Now, I don't know if you guys offer it automatically. Can you tell me about that? Because I learned about it and it was never offered to my mom. And the urine analysis, I was told and learned that it would let you know whether that person is able to come off dialysis. It was a guide. So can you talk about that? Because once I found it, and here's how I found out, you all, I asked questions and I went to Google. Talk about that urine analysis and the importance of it for the patient.
So that is true. A lot of times they won't do that. So they call it a 24-hour creatinine test, which is tests the urine. Yes, so that is true. And sometimes people will request it. I've had patients that, similar to you, they're like, no, I need to know. So they've requested. A lot of times I don't believe that it's done automatically sometimes. So it is good to know about that. And like you said, asking those questions to get that to see, because a lot of times you won't know, especially when you first start dialysis. It's definitely imperative to do that. Then I would definitely say, instead of maybe even you can do it years later, but I think it's imperative to do it in the beginning stages to see the health of the kidney and how likely you could adjust, or maybe they can adjust the prescription some kind of way. But I believe that would definitely be something that would be good to know. And I'm glad you mentioned that. Definitely.
So what does the urine analysis, perhaps I missed it and apologize if I did, but can you tell the listeners, what is it exactly? Is it a test that gives you a guide as to whether or not the kidney is at a point, at a certain number in the urine that you all are looking for that brings them off? Can you tell them that, as well as what numbers they need to be at with their creatinine levels, their phosphate, and their potassium?
Okay. So with that test, what they will do is the patient will bring it back to the unit, and then they'll send it off to the laboratory and they'll test it to see the creatinine, the waste that's in that urine over 24 hours. Because if the kidneys are functioning,
so they measure the waste. They measure the waste in the urine. Okay.
During the 24-hour urine period. Yes. So that's what they're very clear about it. Like, it has to be 24 hours. So they'll definitely say that it has to be 24 hours. Like, you can't do 52, 3, because some people have done that, and you can tell, they'll know it. They're like, no, this wasn't 24 hours. So it has to be 24 hours. And what they'll do is bring that urine sample into the unit, and the unit will get the urine out there, and they'll send it off to a laboratory where they'll test that and see what the creatinine is in that urine for that 24-hour period. And seeing that, sometimes they can see, okay, this is the urine functioning. What they have, maybe they don't have a lot of creatinine. The numbers aren't high for that, or maybe they're lower. Or sometimes people will request it multiple times over a duration of a couple months to see, well, maybe it wasn't good then. Let's see what it is now. But they test the waste within that to see how it is and how your kidneys are clearing within that 24-hour period.
And if your kidney obviously has cleared pretty well, then it's a good chance you can come off of dialysis.
Or what they'll do is start probably decreasing the time frame. So that maybe a person starts at 3 hours. They'll say, okay, we're looking at this 24-hour creatinine clearance test, and we're seeing that, okay, this is good, or this number is this. Let's decrease the time by 30 minutes. And then they'll keep doing that. And then eventually, sometimes they may see like, okay, they don't need this anymore. Like their kidneys are doing well. But like you said, like you asked for that. Sometimes people don't know and they don't ask for it. And they just stay on the dialysis machine with the prescription and just keep going because they don't know that.
Okay. Would you help everybody to know, again, this is a disclaimer. She's not a doctor. She's not a nurse. This question is just based off of what she's seen. What do people need to do that are told they're going to get a new kidney? The reason I ask that, because I've spoken and talked to a lot of people, and I asked them, well, what is your diet? And they're eating the same thing, but they want to be on the list for kidney transplant. You can't be on the list. You're not going to have a kidney transplant if you don't change your diet, right? If you're on dialysis, there's a reason why you're on dialysis. If you want a kidney transplant, your kidney has to be in a certain state for it to be transplanted. Correct?
Yes, that is true. So I am a nurse.
Oh, you are a nurse. I'm sorry. My apologies. Okay. Okay. So give them those numbers, if you will, because there's numbers, everybody, that you need to pay attention to. Your creatinine. Go ahead. Can you tell them that?
Let me see if I wrote that one down. I have the numbers for that. What those should be.
You guys get your pen and paper out. This is what you need to know, what your numbers should be. And let them know if your numbers aren't matching this, you guys, or close to it or something. If they're higher, you need to go to see a doctor.
So give me a few seconds to get my notebook here.
A viewer said while you're getting that, Maisha sounds like a very attentive caregiver. We need more care workers like her that will assess the patient and talk to them about how the patient is feeling. I needed her when my husband was going through dialysis. God bless you, Maisha. He has given you a heart that cares.
Thank you. Thank you. That is the goal. The Lord helped me to keep being that way, for sure. So for the creatinine, the normal levels for that should be between 0.74 through 1.35 milligrams per deciliter. That's for adult men. And then for let me see here. For the women, it should be 0.6 to 1.1 milligrams per deciliter. So
what she's doing, everybody, she's giving you numbers where your numbers ought to be for your creatinine level, for men and for women. Okay.
Yeah. So again, those for the men, adult men, normal level should be 0.74 through 1.35.
And then go ahead. I'm sorry.
Go ahead.
No, go ahead.
And then for women, it should be 0.59 through 1.04 milligrams per deciliter.
And what is the approximate number that if you find your creatinine level at, that you have to go on dialysis? Approximately.
Okay. I have another slide here for that too.
Okay.
I have these little papers. I think I left those over there, but I can look at that. Because what I've seen is anything with our patients that I've seen start anything over 2 or like above these numbers, they're starting them on in the hospital is what I've seen for sure.
Yeah, and I asked that because my mom was at 2.78 for her creatinine for quite a while. And the doctor kept saying, take her to a kidney specialist. But I got no other information, so I didn't know what that meant. So here's what I want to share with everybody. Keep a check on your blood work for your kidneys and your heart. Because again, if you have congestive heart failure and you're taking medicine and your diet is not proper, eventually, correct me if I'm wrong, Maisha, but what I've heard and what I've seen and what I've researched and learned, quite often people will end up on dialysis if you have congestive heart failure, as we said, diabetes, and you have high blood pressure, and vice versa. So you want to make sure that you go and get yourself checked out on that creatinine level. Can you tell us, are you able to say what people should do to keep their creatinine level down?
That should be primarily regulated by the kidney functioning. So I don't believe there's anything that someone could do personally to help keep those levels down or within normal range. It's the body's kidneys that are functioning and doing that automatically.
Okay. Can you tell them what their numbers should be for phosphate and potassium? So remember,
Okay,
you
so
guys give that, yeah, you guys give that
oh, go ahead.
report. I want you to let them know what those numbers should be so they can keep a
Okay,
check on their kidneys.
so potassium, you don't want potassium over 5. So the normal levels ranges for potassium is 3.5 to 5. Anything lower than that or higher than that can affect the heart and how the heart rhythm beats. A lot of times, if people have higher potassium levels in their body, they have arrhythmia, which is irregular heartbeats. A lot of times, people don't understand, like, well, my heart beats this way or different things like that. If that potassium level in the body is too high, that can cause heart attacks. It can cause all kind of issues with the heart, but it doesn't run or beat regularly and normally how it should if it's above those levels. And those ranges again are 3.5 to 5.
And that's for the potassium or the
Potassium.
phosphate.
Mm-hmm.
Okay. What should
Potassium.
it be?
And then I'm gonna
What
give
should it
you.
be for the
Go ahead. I'm
phosphate?
sorry. The phosphorus, I have wrote this one down too because I don't know those numbers off. That's 2.8 to 4.5 for the phosphorus in the body. So anything higher than that, a lot of times I've seen too with the kidney patients that have higher phosphorus levels, but they also give you the binders to help you to, how do I want to say this nicely, eliminate the phosphorus.
Mm-hmm.
Yeah.
And can you
Add on there real quick, if I can,
no, go ahead. Go ahead.
concerning the potassium levels. Know what foods are high in potassium, and then modify the diet. Now, my mother liked greens, so they're high in potassium. So the rule became you can have greens, and this is per the doctor helped us out with this. But what you'll do is soak those greens and get a lot of that potassium out of there. So soak them, for a bit. You see all that green come off of them, a lot of the chlorophyll. Soak them again, and then cook them. And then I would only give them to her the night before she was going to have dialysis so she could have it, but it wasn't because her potassium would go up. That was a problem. So know the foods that have potassiums that you really like, and then maybe you can modify how you prepare the food and give it to them at the right time.
Yeah.
Yeah, that
That's
was
great.
good.
Yeah. Yeah, and they can modify. Here's another tidbit because we're getting ready to shut it down. And thank you, Shakina, for putting those numbers up. Unfortunately, StreamYard is not showing the comments. Something happened. But you guys listening, phosphorus is high in potatoes. I think it's fair to say, Maisha, and if you would agree, that as we get older, you all, your body just can't handle certain foods. Like it can't process certain foods like it used to. And if you're on different medications, that's going to make it even worse. Some conditions are medicinally induced. My mom's condition was medicinally induced by a medicine called hydralazine. If you are taking hydralazine, it will eventually damage your kidney because it will cause lupus. And that's what happened to my mom. It caused lupus. and the numbers were so high, it just tore her kidney. It just ripped it, in terms of the functionality of it. And so you got to watch potatoes and you got to watch macaroni and cheese. You all do your homework and look up these foods that have too much potassium, as Dr. Val said, and Maisha, and look up the foods that have too much phosphorus. Maybe when you were younger, you could down those potatoes with no problem, baked potato with the sour cream and the butter and all that stuff. But guess what? You in your 50s now, you need to chill with that. And if you're not working out, that's even worse, because at some point it's going to catch up with you. So we have to do what we have to do to make that shift change with your diet, because anything can happen that will totally destroy your heart and your kidney. I like to say, from studying and talking to professionals such as Maisha and others that I have learned and are my friends, that the heart and kidney are cousins. I did this show because so many people ask me, what did I do for my mother? I'm telling you what I did for my mother. I'm telling you that it wasn't me, it was God. God led me to change her diet. I took my mom off of a lot of meat. You guys, you might have eaten a lot of red meat in the past, but Maisha, too much protein is bad for the kidney too. Is that right?
Because if they're not functioning right, that'll start spilling over in the urine, which is, yes.
Yeah, and that's the animal protein, right? And then it also causes a leaky gut, I believe, too.
Yes. Yes. And tell them what the protein number should be.
Okay, protein. I got you.
Listen, you guys, you got to change your diet. If you want to, my dad told me a long time ago, take care of your body now so that your body can take care of you later. And that involves a lot of water. Kidneys love water. If you're fasting, as you get older, you can't fast sometimes the way you used to fast when you were younger. You got to drink some water.
But don't you have to modify the water intake, because if the body is not urinating it out and you have to wait until your next treatment, you have to modify the fluid intake?
Yeah, well, I'm talking about for people that don't have kidney problems yet.
Oh, okay.
Yeah. If you got kidney problems, definitely. Thank you, Dr. Val. Yeah, but I wasn't talking about that, but that's a good point. Did y'all hear her? If you got kidney problems, you have to monitor your intake of liquid. Your doctor should be able to tell you. My mom was put on two bottles of water a day. Go ahead. What should the protein be?
Protein level should be 6 to 8.3 grams per deciliter. So those are the normal levels of protein that people should have, like for their lab levels.
So everybody, we're getting ready to shut this show down. Maisha, I think this has been very helpful and educational. I hope and pray that you all will share this, because there's a lot of people on dialysis and some of them can come off. Ask the questions. I want to reiterate it again. Ask the questions. Get your blood work done. When you get your blood work done, don't just put it aside. Go and get the report. Require your doctor to sit down and explain. And if they don't, if they won't, then get on Google and see what that stuff means. That's what I did. I was relentless. I would go in there and tell them, well, I saw this on Google, and they would say, well, you can't trust Google. But you know what? I told them I trust Google and I trust God. Both of them start with G. And guess what? The Lord bless her to come off of dialysis. So you guys, do your homework. Make sure you stay before the Lord. Change your diet. Watch your medicines. Another bad medicine, I'm going to throw this out there. Maisha, you can, and Dr. Val, you can vouch it if you want or not. But you guys, if you can, get off of that metformin. Metformin will mess your muscles up. It just tears you up. So the more they give to you, the worse it is. I have an article where metformin, it helps for diabetes, but it kills as it's helping.
Can I say that when you do your research, don't be quick to go straight Google. I would go Google Scholar, because Google Scholar is going to have your peer reviewed and the peer reviewed and scholarly articles. So that way it's someone that is trained, and it has to be reviewed and accepted by their peers. And as opposed to one person putting it out there. But those are good sources of information. If you go to Google Scholar, get those peer-reviewed and scholarly articles. They'll give you more substantive information.
And pick up books. Pick up books. Read articles. I did that. I picked up books. I read articles. I talked to professionals like Maisha. I talked to doctors. I mean, I just did not rely on one piece of information. So as we close, Maisha, what is your last word you want to say tonight? And I hope you'll come back so we can do a part 2, because I got a whole lot more questions. She said, so we've got a viewer. Before you give your last words, the viewer said, what was the protein again? What numbers should your protein?
6 to 8.3.
6 to 8.3. And by the way, I had a relative who died of kidney failure because too much protein leaked in the kidney. That's what started that demise. And my relative was on dialysis as a result of that. And dialysis went so long, and that person got so sick that near the end, the flesh started coming off the body.
Can I ask about the plant-based versus animal protein? And I know you got to get to your mom, but I just wanted to say, is plant-based considered better, safer, recommended more than the animal protein?
That would be a question. Honestly, I don't know the answer to that. I would reach out to some dietitians. I actually want to know myself. I would think it would be, but I want to ask them about that in regards to different things, because a lot of times that plant protein items are very processed in a way. So I would definitely have to ask them about that. How would they feel about that with the dialysis patients, or even people that may want to change their diet before even getting to that state?
Okay. So in answer to that, Dr. Val, what I was told by a few doctors, and then I did a little research. I'm not a doctor, so again, you all, disclaimer. But for my mom, I asked those questions. Excuse me. I sorry, you guys, got a bad little cold here. But I was told that the animal protein is better because it's, I guess, natural, like it's the animal, but to be selective of which animal. And so it was better for her to be on chicken and fish, seafood and chicken. And if you can come off chicken, come off chicken. You know what I mean? For those that have problems with your diet right now, or your kidney or your heart, sometimes people need to go vegan. Sometimes they need to, go in the middle. But whatever you do, you have to do it in modesty. So I just shaved her meat. I shaved her meat. That's what I did. For 2 days a week, she didn't have meat every day. And then when I gave her meat, if I gave her meat on those 2 days that she wasn't supposed to have it, it was a smaller portion.
Yeah, and I would say to even check that plant-based, as you were saying, because a lot of those beans are proteins, but then they have those lectins in there. Some of them do. Some of them are good, but some of them have those lectins in there, which they block the body from fighting off fats. So they cause other problems. So I'll look that up.
Yeah, and so that was for her. I think it's going to depend on the client. I think it'll depend on the patient. She, her heart got bad, so the blood could not pump as strong from heart to kidney and vice versa. So it was better for her body to process chicken and seafood. And still today, I don't give her a lot of red meat, and I wasn't giving her pork. So I changed her diet and kept her off of that meat type, that harsh digestive meat, beef and all of that, pork. Kept her off of that for 9 months and did a lot of stir fries. Some people ask me what kind of food did she eat? A lot of stir fry, a lot of cruciferous vegetables. Cruciferous vegetables. If you got kidney problems, or you are afraid eventually you might end up with it, don't eat a lot of foods, again, with potassium. A lot of people like spinach. Spinach is high in potassium. As Dr. Val said, her mom liked greens. Certain greens can be high in potassium. And by all means, Black people, y'all know we love some black-eyed peas and pinto beans and all of that. But I'm here to tell you that stuff will kill you if you are not careful, because they're high in potassium. They are very high in potassium. So I had to take my mom off of those beans as well. Sweet potatoes, high in potassium. So just check the record. Follow yourself very carefully through blood work, and let the Lord, lead you. Go ahead, Maisha, your final words to the audience.
final words I want to say. First, I want to say thank you for having me on the show to even elaborate and just talk about kidney disease and what it means. I just want to encourage anybody that's dealing with a person, that loved one that's on dialysis, or they may have to go on dialysis. I would encourage them to ask a lot of questions. Do not be afraid to ask questions. Also, if there's something you're unsure about, reach out to someone that can help you. Also, reach out to family and friends that may have experienced it or even know a medical professional that can assist you and help you with that. And also, if you're not feeling well on your dialysis treatments, make sure you talk to the nephrologist to communicate that consistently so you can feel better and also get the help that you need. Another thing I want to say is some sites that can help people that may need a little bit more information about kidney disease is the National Kidney Foundation.org, AmericanKidneyFund.org, as well as I want to tell people about an association that helps kidney patients. It's called American Association for Kidney Patients. And that assists patients that are on dialysis. It's a community. They support each other. There's also a lot of information that will tell each other to help them during this process.
Awesome. Thank you so much. And hopefully we will schedule you to come back again. And Dr. Val, last words?
No, I think she said it all. And I think I just would encourage everybody to come back and listen to this, because some things we may be doing seem totally harmless and healthy. And we're actually creating problems for the future that are way above and beyond what we expect.
If y'all don't do nothing else, play that last line she just said, because that's just it in a nutshell. God bless you all. Have a good night.
Thanks, everyone.
And we hope and pray that you will share this. Thank you again, Maisha. Thank you, Dr. Val. I love you both. God bless.
Love you. God bless.
Yeah.